We have excellent treatments for hepatitis B, and they've held the line very well. I guess one of the limitations, of course, has been interferon. It doesn't work in every patient, and you can anticipate something like 20 to 30% response rates. It's, of course, very difficult to treat hepatitis delta infection, and the only treatment we have is interferon, but the response rates are not very satisfactory, perhaps about 25%. Although the nucleoside analogues are potent inhibitors of hepatitis B, they have to be given in the main as maintenance therapy. So that's a limitation, and we have to commit most patients to treatment for a long period of time. Now, we are trying to work out in whom we can stop therapy. It's possible that those E antigen positive patients who've lost E and seroconverted to anti-E could try stopping therapy, but there is the anticipation that there'd be very high rates of relapse in those individuals. So a limitation is we have to have a proper protocol in place to actually monitor them after cessation of treatment. I think it's very difficult to stop treatment in the E-negative patients, but again, there are protocols in place under appropriate conditions to try to stop. But that's the main limitation. It's a long-term continuous therapy. What we're not achieving with the current treatments are high rates of cure, in other words, loss of HBsAg. We're holding the line very well with maintenance suppressive therapies. Far fewer patients are progressing to liver failure. We think we're having an impact on primary liver cancer. But our sights are set on cure of hepatitis B, eradicating HBsAg with new direct inhibitors, capsid inhibitors, perhaps entry inhibitors, compounds that will directly affect cccDNA within the hepatocyte, and immune modulators. That's for the future, but if we fast forward for 5 years or maybe 10 years, I'm sure we will have overcome some of the current limitations, which in the main are insufficient rates of cure and finite treatments.